Kim, thank you so much for doing this.
No problem.
So Kim, I wanted to give you an update on, how we've been collecting data from you and collecting data from everybody in order to look at the success of the program and then what lessons we can learn from the numbers that we're studying. And so we started back in December of 2018 with the ED Bridge, and it's varied in terms of how available the peers have been.
Right.
Sometimes you've been available by phone, more recently right there in the ED. But over time in general, what the numbers tell us is that literally the patients are twice as likely to successfully get from that ED encounter with the physician intervening in some kind of way, whatever was appropriate for the patient, and then getting them into treatment in an outpatient setting. So the support of the peer has made this huge difference. That's one of the key lessons that we've learned from looking at the data. So thank you for collecting the data. It's really helped to inform, how we help other hospital systems to get an ED bridge into place. In general, the first year, our level of success of getting a patient who was appropriate for outpatient care, and as you know, not all are appropriate for an outpatient level of care, but for those for whom it's appropriate, we got 82% into treatment. And after a month, we looked at how many stayed in treatment, and 90% had stayed in treatment at the end of the first month. So that was also encouraging data. And in year 2, we kept it at 78%, and we haven't yet gotten our year 3 numbers back. When we started embedding the peer into the ED, I noticed that he was seeing as many as about 33 patients in a month. So he's been busy.
Yes.
And so not every single one of the patients that he sees is an opioid use disorder patient. Of course, he's, available to work with mental health patients and patients with other kinds of substance use disorders. But the great bulk have been opioid use disorder patients that have come in and that he's seen. The greatest percent are, in fact. And so he has been that person to connect them with the social worker. Now that we have the iPads in place, they can do that immediate connection right with the social worker. And that has led to successful placement, also. Those are very likely to be successful. In general, we tend to keep patients in outpatient care as long as we can, honestly.
Right.
When I was first going into this field, I was studying the research that's available. And what they found was that patients who stayed in treatment for, 2 years and then 3 years were significantly more likely to recover, to not die from their disease. It's really a matter of life and death.
It is.
So we've made it an aim of ours to keep people in treatment. I think there's a misunderstanding out there. I don't know if you've run across this misunderstanding that people think that you've got to get off that medicine.
Yeah.
As if the medicine is something terrible.
It is. It's definitely a thing that I always have to put in the back of my head when they are reaching out to other programs, because there's other programs that do the same thing that you were saying, and a lot of times I have to think about that when I share my information, because I don't want to set them up for failure, because that scares them. They're already like, no, like I can't just, you can't just take that, and so I've seen where they've been in other programs, they've been kicked out, or something has happened, and there was no follow through because they were done. And that's where us peers come in, and then if they're fit for the Carilion program, it's even better, because we just open communication. You do your part and we're going to do ours.
The forced taper, that some programs have in place, where they say, you can only be here for 6 months, and then, you need to get off of it.
That freaked me out. I mean, I was in a program on Suboxone somewhere else, and it was just in my head all the time. I was like, well, they're just going to take it away from me, whatever. You know, like it's not treatment, you know, it's nothing positive. It feels like something's wrong with you for being on it. And that is so not the case.
Yeah, we like to compare it to insulin. That,
Right.
you know, if you're a diabetic, you need ongoing treatment. And sometimes your body will get to a point where you need less medication. And that may happen. But some people's bodies don't get there, and you need to maintain the insulin for a very long time. And to me, that's comparable to what buprenorphine does, or as you've called it, Suboxone, is that it helps recalibrate the brain, you know, how the neurotransmitters work. And sometimes you might need that for a very long time. Would you agree?
Yeah, absolutely. You don't know. I mean, we struggled for years. So it takes a while to build things back up and to get our whole body and wellness together. So.
Now, when you work with someone as a peer, how long do you picture that you're going to play your supportive role in their lives?
So it could be tricky. For right now, we are not billing. So we leave it up to the patient. When we factor in the billing part, it could change where, you know, as long as we're working inside the Wellness Recovery Action Plan and doing the necessary services that we're doing, then typically it wouldn't be no more than 2-3 years. It depends, but no matter what, we're still going to help, you know. We're not at the billing phase right now, so I'm not even worried about it. So for right now, it's really, we're always going to be there no matter what, until we are forced by federally, whatever that may look like. There's different rules and regulations with that, so not sure what that's going to look like. But I am going to, we're also always going to have, hopefully through this COVID stuff, to have our peer recovery specialist volunteer program. So, you know, we'll still have our center running, still will be involved. But as of now, you know, if they want to put in the work, we're there with you no matter what. You know, we'll figure it out. And if the peer has more caseload, we will introduce and try to find another peer that will be better fit for them at that time. You know, like, we're not going to be like, okay, I'm sorry. No, like, we will find it, even if it's through our peer program, or we will help them set up with another peer through whatever that is closest to them.
And you have the ongoing groups that they can come back to and be a part of.
Until, you know, we'll have something going on that they can feel a part of and to get back into recovery, whatever that looks like for them.
That's not like there's an easy fix for this, right?
No.
And it's not like you're free and clear of addiction because you've achieved stabilization and recovery.
Right, it is ongoing,
right? Yeah.
And, you know, it's ever changing. You know, we're always working on ourselves. We're always learning something new. And to this day, I'm still working on myself and different things. And, you know, it's a continual thing. You know, I'm going to be in recovery forever. I'm going to be a recovery addict forever. And that is okay. And it just shows that, you know, you can still live a fulfilled life.
Yes, and you can reach out and help so many others the way you do. I think it's really valuable for other healthcare systems to learn about what you have created at our Carilion Clinic because of the incredible value that this program has had for our healthcare system and for our patients. So if you could just describe, for the benefit of other healthcare systems, what is a peer recovery program and what does it look like? Okay,
so a peer recovery specialist program is individuals like myself that are in recovery from substance use or mental health, or both. All peers are in recovery themselves. And basically we have shared lived experiences and we give back to the community, to our patients, just to show, hey, we've been there. You know, maybe not necessarily the same situations or the same path, But what peers believe in is we believe in all different paths of recovery, whatever that may look like for them. So the patient really is in charge of their recovery. And then the peers are, they're little, I guess, cheerleader, so forth, to share like, hey, like, if that's what you want, like, I support you. We will get there, however way that you want to. We believe that, obviously recovery is possible. And for the patient itself is, they tell us what recovery looks like for them. So we just support them, encourage them what that may look like.